Good morning. Thank you to Debbie's Dream and Christy specifically for asking me to speak. So my talk is going to be pretty broad, chemotherapy, targeted therapy, and immunotherapy. And I wanted to talk broadly and not have a ton of data and fancy slides and Kaplan-Meier curves and things like that. I did add some because I thought I needed some. But I tried to approach it from how do I think about the patient when they come to clinic and what's the patient or the family going to want to know. So by outline, so basically I wanted to talk a little bit about epidemiology, 2 slides, then what are the options, and then a little bit about the basics of each type of treatment, how it works, what we think about, and then most of the talk is, or I guess maybe the latter half, is how do we use them. Localized disease gets very complicated, as Dr. Blackstock kind of alluded to, so there's some things we do easily, so I was going to touch on that a little bit, and then more on sort of stage 4 disease, because that's more where chemotherapy comes, and targeted therapy and systemic therapy come along. So as Dr. Shaw alluded to, we don't, or lots of people have said, we don't actually see that much gastric cancer in the US. So this is from 2017 data, about 28,000 cases of gastric cancer in the US, which is sort of pales in comparison to either breast cancer or lung cancer or colon cancer. Over the years, there has been a decline in gastric cancer incidence, although I'll tell you in my clinic, it certainly doesn't feel that way recently. But the other thing that I think is important, I'm not sure which one is the pointer. Oh, is that if you can see over the years from 70s to 80s to 90s, we definitely have made progress in how well people are doing. It's not super leaps and bounds, but we're getting there, and I think as we continue to go along, we'll get further. In terms of risk factors, this is something patients ask me is, where do you think this came from? Most of the time we don't know where cancers come from, but things that I think about in general are smoking generally can cause any kind of cancer. There's an increased risk for male gender, generally advanced stage, although as we've talked about, we're seeing more and more young patients. There seems to be some link to diet, nutrition, obesity, environmental factors, and then very rarely we see families with genetic syndrome. So it's not the most common thing that I see, but there are a couple things in terms of the Lynch syndrome, which puts you at increased risk for stomach cancer, or hereditary diffuse gastric cancer syndrome, which I don't know if Dr. Hodge will talk about a little bit or mention anyway. So moving on to chemotherapy, I talk fast, so I'm going to try not to talk fast. So basically, the basics of chemotherapy, so it used to be that I only talked about chemo. Now I have to talk about chemo, targeted therapy, immunotherapy. Chemotherapy in general is essentially poison that kills cancer cells. So the way I think about it is most of the drugs that we have that are chemo work on DNA building blocks. If you can't make DNA, you can't make a cell, you can't grow. There are some nuances to different types of chemotherapy and how they work, but in general, it's basically the building blocks of how a cancer or any cell grows and divides. It basically affects those and makes that machinery stop. And as a result, it can affect normal cells as just as much as it can affect cancer cells, and that's where most of the side effects come from. And that's why I think we're trying to move away from true chemotherapy, which is cytotoxic, to more targeted therapies or immunotherapies. There are many different types, and I'm going to show you a laundry list of different drugs, more to sort of just give you a broad breadth of all the different options one can use for gastric cancer, although in general, in my clinic at least, it boils down to a few things that I kind of always generally do. But the type of chemotherapy that you might choose depends on the cancer type, what other medical conditions the patient has, how old they are, do they have bad heart disease, do they have bad lung disease, are there other things, other ways that you might hurt them if you give them certain types of chemotherapy. And then also in the goals of therapy, so as several people have alluded to, sometimes the therapy is worse than the disease itself, and so you have to think about what you're going to get and how you're going to get there, and do you want to take the risks associated with chemotherapy. So these are all this is the laundry list I was talking about. So in a good way, there are multiple different things that people have looked at and multiple different agents you can use. So This is not even all-inclusive, but this is a pretty long list of all the different chemos that you can use, each of which sort of fall into a few different categories. And then you can combine these into different regimens, which we give short names for because it takes a long time to say all of these things all together. So some of these are very common, and I'll talk a little bit more, but I just wanted to sort of hit the basics. And some of these you won't see come up again because they're not ones that I typically commonly use. In terms of side effects, basically side effects of chemo are caused by effects on normal cells. So it's most of the things that you think about. So as Dr. Blackstock mentioned, most people, unfortunately, have had some experience with someone they know having cancer and getting chemo. So most people think of hair loss, nausea, vomiting, diarrhea, feeling bad, losing weight, all sorts of those things, or being susceptible to infection. All of those things are just because any rapidly dividing cell can get hit with chemo, just like any cancer cell can. And so that's what causes the side effects. And really, it's my job as a medical oncologist to try to minimize those side effects as much as I can. Sometimes we can, sometimes we can't. And each drug has its own specific side effect profile, which I'm not going to go into specifically, but when you meet with your oncologist, you need to make sure you understand exactly what might happen. And luckily, most of the time you get this big laundry list of things, and maybe 2 or 3 of them you get. Sometimes people get all of them, and then you have to think hard about if you want to continue. So that's sort of just the general basics of chemotherapy. Targeted therapy gets more specific. So chemotherapy basically gets everywhere, kills everything. The goal of targeted therapy is to try to select what you might actually be killing. So there are multiple different approaches or mechanisms by which these drugs work. So you can either, basically, there are pathways within cells that tell them to grow and divide. You can try to block those pathways. And so certain drugs target pathways. Certain drugs, one of which I'll talk about, interferes with tumor cells making blood vessels, because if the tumor cell can't get blood, then it can't get nutrients and it can't grow. And so you can add that together with chemotherapy. Sometimes you have a target. So there are some drugs where it's connected to a chemotherapy, so it basically drags the chemotherapy to the specific target. There aren't really any of those we use for gastric cancer, and then some of them affect proteins within the cancer cell. So it still can affect normal cells, but to a much lesser degree. So the things that you might hear about in gastric cancer, there's basically there's been a lot of work done on targeted therapy, so I didn't want to go through, here's all the work we've done, and here's kind of what didn't work, but I wanted to focus on what we do use. So the big thing that's been mentioned is HER2. So HER2 is a story that started in breast cancer, and most people have heard of Herceptin or trastuzumab, which is the big drug that's used in breast cancer. About 20% of gastric cancers will overexpress HER2, and I'll explain a little bit about what that means. But what that means is if you have a normal cell and a tumor cell, the tumor cell has more copies of the HER2 on its surface. So if you send something that will block the HER2, you can preferentially target that cancer cell as opposed to a normal cell. But the issue with the HER2 is if your cancer expresses it, you can get trastuzumab and it will hopefully be helpful. If your tumor does not express it, Herceptin or trastuzumab is not going to work. And so the way I explain it to my patients is it's not really good or bad. It's a thing. You figure out the data and then you move on. The other targeted therapy is VEGF targeted therapy, and the drug we use here is ramucirumab or Cyramza. And this basically targets the VEGF pathway, which is the one that targets tumor blood vessels. So I'm going to show. So this was just a visual schematic of the HER2. So basically, in the cell, the tumor cell is making extra copies of this HER2, which goes to the cell surface and then sits here. And the HER2, there's a whole lot of complicated stuff that people in the lab know that I don't know. Basically, there are signals that come all down. The HER2 gets activated, and it essentially tells the tumor cell to grow and divide. So the basic is you block this, you block all those signals, and the cell doesn't grow and divide as well as it would have. And so that helps kill the cancer. Ramucirumab or Cyramza is different. So similarly, this is a VEGF receptor. So this is the cell surface, and then there's a receptor sitting on the surface of the cell, and there's these signals that come from all of these different all of these different factors, VEGF-A, C, D, that then activate this pathway, and then about 50 bajillion things happen, and the cell proliferates, or it spreads, or it basically does all the bad things that cancer cells do. So in theory, if you block that pathway, those things will either not happen or will happen much less. And so either you can use targeted therapies by themselves, or you can use them in combination with chemotherapy, so you can kind of get the cytotoxic cell kill plus the targeted effect and try to help things work better. So that's kind of the way we put them together. Side effects of these drugs are completely different than chemotherapy because they work in a different way. Trastuzumab, in general, in my experience, really has very few side effects at all. So it's an antibody medicine, which mainly people complain of fatigue. And the big thing actually we watch for is cardiac dysfunction. So before you start Herceptin, you have to get an echocardiogram to make sure your heart functions well. So in some older people that have had heart disease and they may have heart failure, they would not be candidates for Herceptin just because it would hurt them. And then you have to get an echo about every 3 months to make sure that you're not having some effect on your heart. If you do, you can stop the Herceptin, and if it gets better, you can reintroduce it. But you just have to be very careful. Ramucirumab, on the other hand, affects, like as I said, blood vessels. So just like it affects tumor blood vessels, it can affect normal blood vessels. So the side effects that we see include hypertension, which sometimes can be very severe and other times doesn't happen at all. Proteinuria due to effects on the kidney blood vessels, which is something that we have to watch for. And as long as you're paying attention you stop the drug before you run into trouble, you won't have any kidney dysfunction related to it. Wound healing problems, because if you can imagine, if you're trying to heal a wound, you're going to need blood vessels. So one of the things we think about is if somebody is going to need to have a surgery or has recently had surgery, we wouldn't use this drug until we know things are fully healed. There's an increased risk for a heart attack and stroke, which sounds really scary every time I mention it, and I wonder why anybody would even let me give them this drug, but it's generally, if you give it to the right people and you're careful, we don't see it very often. And then there's a risk of perforation, which just means a hole in the wall of the bowel, which also sounds equally terrible. So that's targeted therapy in a nutshell. So ramucirumab can be used alone. Herceptin is usually used in combination with chemo. Immunotherapy is the big new thing. This is what all of my patients are asking me about. So it's the newest group of agents. It can also be used used alone or in combination. So I'll get to it a little bit later. Usually it's used alone in gastric cancer, but there are studies going on looking at combining it with chemotherapy, so along the same lines, or actually even combining it with immunotherapy or targeted therapies, although those are a little earlier in development. So there are different ways you can affect the immune system. I'm going to focus on checkpoint inhibition because that's what most people are hearing about. So the drugs we hear about, I'll talk about in a minute. But basically the way I describe this to patients is these drugs are trying to help your immune system target the cancer. So a cancer cell comes from a normal cell, so it looks very much like self. So your immune system typically can't find a cancer cell and doesn't know to kill it because it looks so much like a normal cell. What these drugs do is they basically allow your and what happens when you get an infection, your immune system revs up, checkpoints kind of turn off the immune system so it doesn't go haywire. So the checkpoint inhibitors, which is Keytruda and Opdivo, the most common ones people hear about, basically turn off those checkpoints so your immune system can be much, much more active, and in theory should find the cancer cells. That's kind of the way these drugs are designed to work. So the two most common ones is there are many of these, but the ones that I think about in general, as it relates to gastric cancer, are pembrolizumab or Keytruda, and nivolumab or Opdivo, which they're advertising on TV, so most people are familiar with these. So there are two scenarios in which I think about these drugs. So there's a special population of patients who are called MSI high. And those patients, so you have to specifically test for that. So this would be something, if you are newly diagnosed with gastric cancer, would be to ask, have you had microsatellite test? Has your tumor been microsatellite tested? I never do the best job explaining what microsatellite testing is, but basically it's looking to see if your tumor is somehow missing enzymes that help repair DNA mismatches. so that if you don't have these enzymes, your DNA has many more mismatches and many more mutations, and it can be found easier by your immune system if it's revved up, is the general thinking that I think about. So there's a very, very small population of patients that have tumors that are MSI high. Those tumors will respond very, very well to immunotherapy. And when I say small, it's probably in the colon cancer population is about 4% of those with stage 4 disease. So it's pretty tiny. But if you fall into that category, there's a pretty huge impact that immunotherapy could have on you. And so basically, I test everybody who comes into my clinic, which I realize is looking for a needle in a haystack, but it makes a big change in therapy. So sometimes those patients who have MSI high tumors are patients that have the Lynch syndrome or have a familial syndrome. Sometimes they're just sporadic cases. If one does not fall into that MSI high group, then in the general population, the way we decide if you're a candidate for one of these drugs is to test your tumor for PDL, which is the target of these drugs. So the Keytruda is the one that's approved for third-line therapy, and they use the combined positive score. So I put it down here. So what they do is they basically take your tumor cell on a slide in the pathology lab, and Dr. Gully may talk more about how this is done, because I'm not doing the greatest job. But they stain it, and they look at the number of PDL positive staining tumor cells, and then they look at the total number of viable cells, and then they give you the score. And basically, per the FDA indication, if your tumor has a CPS score of 1 or greater, then you would be considered a candidate to get the Keytruda. And if not, then you wouldn't, and that's mostly because it, in theory, wouldn't work for you. So that's sort of the basics of immunotherapy in terms of how we think about it and what you have to know. In terms of side effects, again, these are vastly different than chemotherapy side effects because they're driven by your immune system getting overactive and attacking something in your body. So you could have inflammation of basically anything. The most common things we see are thyroid problems, rash, diarrhea, which is due to an inflammation of the colon. Less commonly, you can have things like inflammation of the lungs, adrenal insufficiency, myocarditis, which is inflammation of the heart, or inflammation of the brain. So you can have some very bad things happen related to immunotherapy. Most of the time you don't have those, but sometimes you can get things that are very severe. So that's kind of the basics of how the drugs work and sort of what the options are, what side effects you might have. One thing I did want to touch on, because as I was listening to the talks, I realized nobody touched on is what should be the initial workup when you get diagnosed. So most people have an endoscopy, and then endoscopic ultrasound is a test where you look to see how far through the wall of the stomach the tumor goes and kind of what the lymph nodes are. Then you should have a CT scan. And then the big thing, which is the point I wanted to make, is that I would advocate for a multidisciplinary evaluation, which would include a surgeon, a medical oncologist, and a radiation oncologist. So as Dr. Blackstock alluded to, many times, probably less so now than when I started, these operations happen in the community, and a patient sees a surgeon and they have a surgery, and then we meet them after. And it's becoming a little more clear that there are often things we could do before to either improve the surgery or do other different things. So I think having everybody on the team meet and decide what the best step is makes the most sense. And sometimes we send people to surgery, sometimes we do some chemotherapy first. But I think having everybody in the room to be able to make a decision makes sense. So I just think that's important. So I'm going to make that point. In terms of the goals of therapy for localized disease, the big goal is just cure the cancer. And so the most important component, which you just heard about, is the surgery. It doesn't really matter what I do or what Dr. Blackstock does. If you don't have a good surgeon who does an adequate surgery and gets negative margins and gets enough lymph nodes, it makes it really difficult. It doesn't make it impossible, but to me, I think having a good surgical colleague is the most important. In terms of the other parts of localized therapy, there's chemo and then there's radiation, which people touched on in terms of how we decide what to do. This is a long laundry list of things because this gets really complicated about how to approach this. For very early disease, which was kind of which is kind of alluded to by sort of, can you do endoscopic resection? Early disease, if it's really early, you could think about endoscopic dissection. We actually have 2 of our gastroenterologists who went to China to learn how to do it because they do more of it there. Or not so early disease, but still very early, just surgery and then adjuvant therapy determined based on what we see. For locally advanced disease, meaning positive nodes at the time of initial evaluation or a little bit more advanced tumor, you can do perioperative chemo, so you get some chemo first, then surgery, and then more chemo. As Dr. Blackstock alluded to, this is more commonly done in Europe. Sometimes we do it here. Sometimes you can just do surgery and then have adjuvant chemo. That's actually more commonly done in Asia. You can do what Dr. Blackstock talked about, which is surgery followed by chemo and radiation, or you can do some conglomeration thereof. And there's many different studies that are looking at how do we combine these things. So I wasn't going to go into that in any great detail, but that kind of, again, speaks to having everybody in the room when you decide what's my plan going to be, aside from just surgery, because everybody is very focused on surgery, which is important. As I said, it's the most important part, but the adjunctive therapies are also very important. So the big thing here is that all of this is chemo, chemo, chemo. Targeted therapy is being looked at. So the TOXAG study, which Dr. Blackstock mentioned, looking at the use of Herceptin in HER2 overexpressed patients. There's the other study looking at the use of Herceptin before surgery in HER2 overexpressed patients. And there are some ongoing studies that are looking at immunotherapy as part of the treatment of localized disease, but that's all very early. So as it stands right now, in terms of standard of care, things we have data on, it's chemo, surgery, plus or minus radiation. So for metastatic disease, the goals of therapy are the way I think about it is keeping the patient feeling well while keeping the cancer under control, which is clearly a balancing act that everybody participates in. Systemic therapy typically doesn't cure disease that has spread and can't be removed surgically, and so that's why it's a balancing act. We do want to make sure that people have a good quality of life while we try to treat their cancer at the same time. And this is the setting where HER2 status is used. So as I mentioned, HER2 is still, you would learn it if you're localized, but it wouldn't alter our treatment at current time, but HER2 status would be influential in determining its treatments moving forward. We talk about treatments in terms of lines of therapy, and this is somewhat applicable when thinking about clinical trials. So we talk about the first line of therapy is the first type of chemo, the second line is the second type, and so on. This is important because in thinking about trials are designed for certain lines of therapy, and so if you are looking for a clinical trial and you are newly diagnosed and you've already started a chemo, then you would be wanting to do a first-line trial, but if you've already had chemo, you wouldn't be eligible. So if you're someone who's thinking about clinical trials and you're getting evaluated, you want to find out if there's clinical trials before you start any treatment. Once you've started, then we keep that treatment going until we see and as long as it's working, we don't do anything differently. Once it stops working, that's when you say, okay, now I need to look for another clinical trial, and you'd be looking for a second-line trial. The other reason this is important is some trials have a limit on how many therapies you can have had. So they'll say, well, you can have had two or more, but you can't have had more than 5. And so it's just thinking about clinical trials each step along the way, I think is the best way to do it. Typically, the way I approach, you can do 1 drug or 2 drugs. You can also do 3 drugs. I typically do 2 drug regimens, mostly because there's less toxicity. You can use 3 drug regimens really only in specific circumstances if you want to be super aggressive, if the patient is really young and wants to be super aggressive. In general, in my mind, 3 drug regimens get you more toxicity, but not a whole lot more in terms of survival. In terms of specific drugs, the classes we have are fluoropyrimidines, platinums, and taxanes. Some physicians use cisplatin, which is a really old, I call it an old-timey chemo drug. I don't use it that much anymore. Oxaliplatin is a cousin of cisplatin, much easier to tolerate, and so most of us have actually replaced cisplatin with oxaliplatin. Although I saw a patient in clinic yesterday who started cisplatin, which is not wrong. It's definitely in the guidelines, but I just think it's harder on the patient. And then the other drug that you may hear about, which I don't use, which I think a lot of people are not using, is a drug called epirubicin. which is typically given in a 3-drug regimen, sometimes given before and after surgery, usually used in the metastatic setting. Again, this one definitely just adds toxicity and doesn't add much more in terms of benefit. So I still see some patients that come from the community that have had it, and it's not wrong at all. I'm not saying it's wrong. I just feel like if you're trying to balance keeping someone feeling well and keeping the cancer under control, epirubicin definitely shoves you more into the let's end up with more toxicity. There's also effects on the heart. So if you have a HER2 overexpressing cancer, you don't want to give epirubicin. You don't want to give Herceptin with epirubicin because you can really get into trouble. Oh, okay, I just turned it off. That wasn't what I wanted to do. Okay. So the big thing, which actually Christy reminded me I've said before, is the way I think about this is a marathon, not a sprint. So everybody wants to just get going when I meet them and want to be really aggressive. But the reality is the treatments I give have cumulative toxicity. So even if you do well, the longer you do them, the more tired you get, the more wear and tear there is on your body. So you kind of have to think carefully about kind of what you do and how you sequence things. So in terms of common lines of therapy, first-line treatment, typically Folfox or Zelox, which are interchangeable. So 5-FU and Xeloda are the same class of drugs. Xeloda is a pill, 5-FU is an infusion. But these are, you can use them either one, it doesn't really matter. Certain physicians have different preferences. I prefer Folfox for just, I think it's easier. Or you can do things as a single agent, or as I said, you can do cisplatin. And then trastuzumab you would add if you have HER2 overexpressed disease. So basically, just to give you a little bit of data, if you use single agent chemotherapy, this, not to worry about the numbers, but essentially if you give one chemotherapy drug, 20% of the time you'll get a response. It doesn't really matter what drug you give. And by response, the way we define that is the tumor has to shrink by 30% or more. So this is just to show there's lots of agents that have activity, but it kind of doesn't matter which one. Okay. I don't know what happened. All right. So then the other interesting thing, which I find frustrating, is this is, again, a laundry list of different combinations, which you don't have to pay attention to. The bottom line, though, is if you look over here, the overall survival, it doesn't matter which combination you give, or some of these are European, some of these are Asian, the survival is all kind of about the same. There's a little bit of movement, but in general, it's around 10-ish months. And so that is a little bit frustrating because there's a lot of options, but we don't really have a strong forefront. I would say in the community, the current standard is either Folfox or Zelox. And that's kind of all the thought leaders in terms of that's what we start with. But I do want to be clear, the others are not wrong. They all have data and they all work. But in terms of kind of what we think is the best and easier tolerated would be Folfox or Zelox. So Herceptin, just to give a little bit of data about that. So basically, this was the trial, which now seems eons ago, so they screened 3,800 patients with gastric cancer, and they found 810 that had HER2 positive disease, so about 20%. They then randomized them to get baseline chemo, which they did cisplatin, because that's what we were doing then, or baseline chemo, the same thing, plus the Herceptin. And then you can see, so this red or orange or whatever color curve that is definitely above this turquoise curve, which is, and these orange people got Herceptin. So definitely better. So that's kind of why that's the standard of care. In terms of second line, so the treatments you can use are Taxol or Taxol plus ramucirumab. So here's that targeted VEGF agent. Ramucirumab alone, or some other regimens here. Typically, I use these if in the setting of too much neuropathy, because Taxol can cause neuropathy and oxaliplatin can cause neuropathy. The other point I wanted to make is that trastuzumab or Herceptin is not continued into the second line. So there have been, in breast cancer world, if you have HER2 overexpressed breast cancer, you get some HER2-directed therapy indefinitely. Gastric cancer does not do the same thing. So there have been multiple, we basically said, oh, well, if it works in the first line and it works beyond in breast cancer, we should just do that in gastric cancer. So there have been a lot of different studies that have been done, which is like too much to talk about. The bottom line is none of them showed that trastuzumab in the second line was helpful. So the current standard is, even though lots of us want to think that we should continue it, and for a long time I did, but now there's too much data to say that it just doesn't add anything. So in terms of thinking about decreasing toxicity, cost of care, things like that, it shouldn't be continued. Not to say that people are still not looking at it. So we have some second-line trials. We have one that has trastuzumab combined with immunotherapy. So the idea of putting it in the second line is not gone. We're still looking at it, but suffice it to say, combining it with chemo in the second line is not something standard we would do. So this is just a representative trial. This is the Rainbow trial, which was Taxol plus placebo versus Taxol plus the ramucirumab. And the group who, this blue line, those are the patients that got the ramucirumab and they did better. So that's why that combination was approved. So, oh, wait a minute. Go back. So immunotherapy basically is still under a lot of investigation. Recently, or maybe not so recently now, my ability to track time is not good. Keytruda or pembrolizumab was approved for third-line therapy, so you have to have had 2 different types of chemotherapy first, and you have to have a CPS score of greater than or equal to 1. So that means you have to make sure your tumor was tested for that. So typically, when I meet people, I make sure they get HER2 testing, they get a CPS score, and they get microsatellite testing. So if you're a patient who doesn't know if you've had, and sometimes I meet people, and I make sure I talk to my patients about this. Sometimes I meet patients and they say, I don't know if I've had that. And I'll say, oh yeah, you did, because I have the results. So if you are not sure, just ask your doctor. And if you haven't had it, that's fine, they can do it. But that's, in my mind, you should know whether that's been done and what that means for your cancer. So anyway, if you're third line and you have a CPS score greater than or equal to 1, it's FDA approved. And what that means is that the insurance will cover it. That doesn't mean you can't get it in some other line, but it's not going to be covered by insurance, and there's actually not data to support it. So there are special situations where I think about it, but standardly just in the third line. The thing about immunotherapy is that it's still being looked at. So we're trying to look at it in earlier lines of therapy in different combinations. If you look at the data that got it approved in the third line, which was accelerated, the response rate was about 10 to 15%. So that means about 10 to 15% of patients had their tumor shrink. Or on the flip side, 85 to 90% of people did not have their tumor shrink. So to me, I'm very excited about it, but I'm also skeptical. I'm reasonably young, but I don't jump on the bandwagon very quickly. The key thing about immunotherapy, though, that I think is exciting is responses are durable. So if you were in the group of people that responded, about a third of those people, their response lasted 12 months plus, because we don't have data beyond then, which is amazing for drugs that, in general, have fewer side effects than chemotherapy. So it's very exciting. There are clinical trials going on. In fact, we have one at Duke, which is first line, which is chemotherapy Zelox, so one of the first line drugs or regimens plus Keytruda, and it's actually, it's my trial, but I'm super excited about it. People are tolerating it well, and it seems to be working well. So stay tuned for that. And it's never wrong to ask your doctor about the different drugs. So basically, in conclusion, there's many different options. So I do think sometimes, so I do gastric cancer all day, every day, and I'm probably see most of the gastric cancer at Duke. So for me, it's still not easy, but it's easier because I have a pattern and I know how I do things. I think it's very hard in the community because if you see 1 or 2 of these patients every couple months and you pull up the NCCN guidelines, it's alphabet soup. You could do anything. So it's good that we have options, but I think it is a little daunting for patients or physicians in the community who don't treat it all the time. So we have the 3 groups of drugs, which I talked about. We approach things differently. We're definitely continuing to work on studies and trying to do better, and I think we are moving the field forward. And I would agree with kind of what's been talked about in terms of second opinions. I'm always super excited for my patients to get second opinions because there's more than one way to skin a cat. There's not a book that you open up and says, when Mr. Smith gets gastric cancer, what am I supposed to do? So I'll close there, see if people have questions.
Thank you. We're a little over time, so I was just going to plan to look to see if there's any questions from the audience.
Yeah. I guess a question about HER2. Do you see mutations in HER2, or is it more overexpression in gastric cancer?
It's overexpression amplifications.
Amplifications.
So I don't know that we even, well, I guess in next-gen sequencing, we probably look for mutations, but in terms of what I think about clinically, it's amplification.
Okay. And then those mutations, do you think that the reason why Herceptin does not work for second-line therapy is because you get acquired mutations which can resist the therapy?
Either that, or some people lose their HER2 expression. Like I saw a patient yesterday who had a fantastic response to HER2-directed therapy, and then I rebiopsied him. Long story short, he has no HER2 expression, which makes complete sense in his clinical scenario. And that's what people think it is, because in breast cancer, people seem to keep, the tumor seems to keep its HER2 expression. So I think it's more, I don't know for certain, but I think it's more loss than acquired mutations.
Cool, thanks.
Thank you very much.